Good afternoon and welcome to the DCRI Research Conference, and beginning a new academic year. So I'd like to welcome all of our fellows, and it's nice to see people actually have moved up a few rows, which I think is a great sign that people are looking forward to the weekly conferences and having an engaging conversation. So I'm particularly pleased to introduce our guest speaker today, Brian Smith from the Division of Pediatrics, Division of Neonatology. Brian has been here for a few years. He was here as a resident and as a fellow. He also performed his Master's of Health Science while doing research at the DCRI, and also a Master's of Public Health through the University of North Carolina. So a lot of training. Actually, we were talking a moment ago that the years go by, but they're years well spent when you're building for an academic career, which he has done, and he has done so well. So Brian is going to speak to us today about neonatology, specifically therapeutics and incorporation into best practice. So, all right, thank you.
So again, the title of my project, the proposal that I'm going to discuss today is Neonatal Therapeutics and Incorporation of Best Practices. I received research support from the following pharmaceutical companies. So for premature infants, the healthcare decisions we make for them often determine decades of survivor experience morbidities. And unfortunately, those practices are often based on anecdotal evidence and consensus statements rather than well-powered randomized controlled trials. Very low birth weight infants, so infants that are a little bit less than 3 pounds at birth, less than 1,500 grams, are at increased risk of lots of bad things, and mortality is one of them. About 14% of those babies die. There's numerous morbidities that are suffered in this population. Late onset infections, so infections from pathogens that are acquired from their care environment, from caregivers' hands, from parents' hands, from the isolettes. About a fifth of those babies have a late onset infection during their stay in the hospital. Necrotizing enterocolitis is a catastrophic gastrointestinal condition in which part of the small or large bowel dies. About half of those babies need surgery, and about half of the babies that need surgery die. And then finally, chronic lung disease is a result of the immature lungs of the premature baby that are exposed to prolonged periods of high fractions of inspired oxygen, long periods on the ventilator. And about a fourth of premature babies, less than 1,500 grams, end up with chronic lung disease. And these three morbidities in particular are very important. There's cost, hospital and home care costs that are associated with each one of them, but they're each independent risk factors for long-term neurodevelopmental problems. We know from some comparative effectiveness research that we might improve outcomes by decreasing the exposure of premature infants to certain therapies, and those therapies that are the focus of this proposal include formula feedings as opposed to maternal breast milk feedings, empirical antibiotic therapy, antacids, postnatal steroids. Each one of those has been associated with varying degree to increased risk of mortality and several morbidities, including late onset infections, NEC, chronic lung disease, and long-term neurodevelopmental problems. So this proposal that I'm going to discuss today was submitted recently to the Department of Health and Human Services. We did get a competitive score on it. We're waiting on the funding decision that hopefully will be within the next month. So the purpose of this proposal was to improve short and long-term outcomes in premature infants by increasing the exposure of these babies to human milk feedings and decreasing their exposure to certain therapeutic agents. And we're going to do this by implementing best practices in 25% of the birth cohort admitted to the NICU in the U.S. So the first aim for this proposal is to increase human milk feedings. Our goals are to increase the initiation of human milk feedings from 65 to 80%, and the exposure of human milk at 30 days of age from 50 to 75%. Just a little bit of background on human milk feeding. So when a premature baby is first born, we often don't feed the baby for several days. We typically do this because we worry that it increases the baby's risk for necrotizing enterocolitis. We don't want to feed the baby enterally and then have the baby get sicker over the first couple of days of life. They might get hypotensive or have increased ventilator support, and it might have been a poor decision to feed the baby initially. But once the baby is more stable, we start feeds on day of life 2, 3, 4, 5, 10. We have really two choices for feedings, either formula feeding, so there are premature infant formulas, there's several that we have to choose from, or human milk feedings. We know that human milk typically helps colonize the gut with commensal organisms that are supposed to be there, and that formula feedings, the gut gets colonized with potential pathogens, including gram-negative rods, enterococcus. So the evidence for human milk feedings in premature infants, we have no randomized trials of maternal milk versus formula because of all the ethical considerations that would go into that sort of trial. Donor milk is often used as sort of a surrogate treatment for maternal milk, and there are several randomized trials that have shown benefits to donor milk over formula feeding. So formula feedings in a meta-analysis of several trials were associated with an increased risk of NEC. There's lots of cohort studies showing that maternal breast milk is beneficial over formula. In fact, there's usually about a 50 to 75% relative reduction in NEC for babies that are fed maternal breast milk rather than infant premature formulas. In fact, there's a large cohort study done from the Neonatal Research Network that showed a dose response. So the more breast milk the baby got, the less chance they had of necrotizing enterocolitis. Formula feedings have also been associated with increased risk of chronic lung disease, late onset sepsis, and long-term neurodevelopmental problems. So there's several reasons not to use infant formula. We know that the chance that a mom's going to provide maternal milk to their premature infant is strongly related to maternal race, socioeconomic status, and maternal education. And these demographic characteristics are highly concentrated by geography and vary from neighborhood to neighborhood. And this will come up a little bit later as I talk about the analysis that we're going to do for this proposal. So this figure actually comes from the Pediatrics medical group that we're going to collaborate with in this proposal. They looked at the proportion of infants that were ever exposed to breast milk in all their sites, and it varied from 39 to 97% by site. This figure shows the proportion of infants that were discharged home on breast milk. And as you can see, on the left-hand side, the darker line is the actual proportion of infants that were discharged home on breast milk. There were some units that were near 0%. And then on the right-hand side of the figure, there are several sites that are 70 to 80%. The line in the middle is what you would predict that site's use of breast milk to be based on the demographic makeup of their NICU. And as you can see, the sites on the left-hand side must be actively discouraging breastfeeding to be that low. And then there's something going on right in the units on the right-hand side of this graph where their proportion of infants that are getting breastfed at discharge is higher. So there's something about the culture of that unit, the nurses that work there, the lactation consultants, the physicians, in terms of their ability to encourage the moms to provide breast milk for their infants. Other variables that were found to be predictive of breast milk feedings were sort of things that have been found before: larger babies, white race, older maternal age, and married mothers. The second aim of this proposal is to decrease the use of empirical antibiotics in kids that have negative cultures. And so we want to decrease the mean initial empirical antibiotic course in VLBW infants from 7 to 3 days. When preterm infants are born, the vast majority of them get antibiotics. Probably 90 to 95% of babies less than 1,500 grams get antibiotics at birth. And the reason we do this is because the signs of sepsis in a premature baby are apnea, respiratory distress, and almost all premature babies have those two symptoms. And because you can't tell the two apart from this being a normal preemie or an infected preemie, the babies often get empirical antibiotics. Infection is also a risk factor for preterm birth. Neonatologists use antibiotics so much, the top 3 medicines that we use are antibiotics: ampicillin, gentamicin, and cefotaxime, and vancomycin is number 6. although all these babies get empirical antibiotics, almost none of them have positive cultures. So in 5,500, out of 5,500 VLBW infants in 18 centers, only less than 2% of those babies have positive cultures at birth. We know that antibiotic therapy can modify gut flora, so just like with formula and breast milk feedings, that's probably important in terms of the baby's risk of getting NAC. And in fact, work by Mike Cotton and Danny Benjamin here at Duke with the Neonatal Research Network database found that prolonged courses of empirical antibiotics, so babies that got more than 5 days of empirical antibiotics at birth that had negative cultures, that was associated with an increased risk of NAC or death. You'd wonder why these babies were getting prolonged courses of antibiotics if their cultures were negative. Neonatologists look for almost any reason to give babies antibiotics. And so we'd like to try to stop the antibiotics normally at 48 hours. But if the mom had prolonged rupture of membranes, or if she had a fever at delivery, if the baby's white blood cell count is high, if it's low, if there's a left shift or high blood sugar or low blood sugar, or there's all these reasons. And so a really high proportion of babies end up with long courses of antibiotics at birth. And looking at the Neonatal Research Network, there was a wide variety in practice. So there was one site that only 27% of their babies were exposed to prolonged courses of antibiotics, and then another site that was 85%. So our third aim was to decrease antacid use. So we would like to decrease the proportion of infants exposed to H2 blockers and proton pump inhibitors from 15% to 5%. Antacids are really commonly used medicines in the NICU. Zantac is actually the number 10 most used medicine. The problem is we have no idea how to diagnose reflux in babies, and the symptoms of babies that we think have reflux include bradycardia, respiratory symptoms, apnea. No one's ever been able to show a correlation between episodes of reflux and those symptoms. In the only randomized trial of antacids in babies, ranitidine was actually associated with an increase in episodes of bradycardia. The authors of that study did observe a decrease in bradycardia as the trial went on, and this probably feeds back to as to why we use antacid so much. We give an antacid to a baby, the episodes of bradycardia start to decrease, and we think it works, and it's probably just the baby getting bigger and more mature. We know that low gastric pH is a protective barrier for babies. It can kill bacteria and fungus that gets into the stomach. H2 blockers in large cohort studies have been associated with an increased risk of necrotizing enterocolitis. They've also been associated in preterm infants with sepsis and bacteremia and pneumonia. So here we have a medicine that nobody's ever been able to show that works for a problem we're not even sure really occurs in preterm babies, and that has associated harms. And so naturally, neonatologists give it to a lot of premature babies. And so this figure was generated from a study that was out of Duke. Bill Malcolm is in our division, from Neonatal Research Network data, looking at the proportion of infants that were discharged home on reflux medicines. And so the white bars on this figure are babies that were discharged before 42 weeks gestation. And so those are babies, all of these babies were less than 1,000 grams at birth. The babies that were discharged before 42 weeks were probably less complicated babies. They might have been bigger at birth. They probably went home on less medicines. You can see that site number 1 discharged 2% of those babies on reflux medicines, and site 16 discharged almost 50%. And then looking at the babies that were a little bit more complicated, that went home after 42 weeks gestation, variation in practice ranged from just over 20% to nearly 90%. Just looking at the Pediatrics medical group data, about 20% of their VLBW infants are exposed to antacid sometime during their stay. Usually it's close to discharge. Most of these are H2 receptor blockers, and most of that's ranitidine. But then there are a certain percentage of those infants that get proton pump inhibitors. And finally, the last aim of this proposal is looking at postnatal steroid use for preventing chronic lung disease. And our goal in this proposal is to decrease that rate from 10% of these babies to 5%. A little bit of background on chronic lung disease. So the definition of chronic lung disease is requiring oxygen at 36 weeks adjusted age. So for a 24-week infant, if that infant is 12 weeks old, they're 36 weeks adjusted. And if they're still requiring some oxygen, whether it's on the ventilator or CPAP or high flow nasal cannula, that baby is diagnosed with chronic lung disease. it's an important diagnosis because it's been associated with prolonged impaired lung function later in life and long-term neurodevelopmental problems. In the early 90s, when surfactant first became available, neonatologists were able to stamp out chronic lung disease in 27, 28, 29-week infants, but then found themselves resuscitating more immature infants, 24, 23, 25 weeks. They would give these babies several doses of surfactant, and the babies would remain on the ventilator on fairly high settings with really large oxygen requirements, and wouldn't be able to be weaned off the ventilator. A lot of these babies ended up with tracheostomies and went home on home ventilators. They found that giving these babies steroids, usually dexamethasone, they were able to rapidly wean the babies off the ventilator. There were numerous randomized trials that showed dexamethasone decreased the risk of chronic lung disease in these babies, and this is just a partial list of some of these successful trials. Unfortunately, they didn't look at neurodevelopmental impairment very well. There was a series of trials that came out in 1999, 2000, and 2001 where they found an association between cerebral palsy and the use of dexamethasone. So in the meta-analysis of this, they confirmed this association in almost 1,000 babies. One of the reasons we missed this is because a lot of these trials failed to do the neurodevelopmental follow-up. Almost all the trials were underpowered for this as an outcome. And then finally, there was a really high contamination rate in the placebo groups in these trials. Often 50% or higher of the kids in the placebo group ended up getting dexamethasone, and that was because neonatologists felt like they knew dexamethasone was the best thing for these babies. The baby would be randomized, remain on the ventilator. They would unblind the kid, found out he didn't get dexamethasone, and give him dexamethasone. So in limiting the analysis to just the trials with relatively low contamination rates, the number needed to harm from dexamethasone administration causing CP was only 4. So based on that information, the AAP released a statement 8 years ago saying that routine use of dexamethasone for preventing chronic lung disease couldn't be recommended, that the use, if it's used at all, should be used in the context of a randomized trial, outside of a randomized trial, only in exceptional circumstances with fully informed parents. This data is from the Pediatrics Medical Group, and it's fairly contemporary, so it's 5 or 6 years after that AAP statement. About 25% of the 23, 24, and 25 weekers were exposed to dexamethasone before they went home, so still being used fairly commonly. Looking at the neonatal network data, so again, this data is from 18 academic medical centers, large level 3 nurseries. Duke's been a part of this for the last 10 years. 12% of their babies less than 1,000 grams were exposed to dexamethasone. Again, there was wide variation in center practices. One site didn't use any, and one site, about a third of their infants were exposed. So just from all that background, we know that small babies are exposed to therapies for which overall harm's been shown. And then our priority is going to be to establish best practices to reduce these exposures. A little bit of background on the Pediatrics Medical Group. It's a private group of neonatologists. There's 1,200 neonatologists. They cover 278 NICUs in 33 states, and a fourth of all the babies admitted to a NICU in the U.S. go through a pediatrics NICU. We have collaborated with them in the past, and we're collaborating with them on this proposal because of their electronic medical records. It's a proprietary product. They call it Baby Steps. They developed it about almost 15 years ago. It's helped them with research, it's helped them with education, and helped them with internal QI projects. This electronic medical records will collect all the data that we need for this project prospectively. It's collected on babies on admission and daily until they go home, and it's transmitted daily to a central repository. Currently, their data warehouse that collects all this information has information on more than 600,000 infants. And so as an example, some of the variables that we'll be able to collect that we'll need in this project include for human milk, we'll know the type of initial feeding, what they're being fed on day 30, what day they started feeds. For empirical antibiotics, we'll know what antibiotics they got, when they started. Did the infant have a positive culture? So if an infant has a positive culture, it's probably okay for that infant to be on antibiotics, but we're interested in the ones that had negative cultures. And then for antacids and for steroids, we'll know which one was started, when it was started, and why it was started. Just an overview of this project. So there's 3 major steps in this project. There's going to be an initial intervention that will be rolled out in 2 formats. One at a quality summit, and the second format is going to be at the point of care within the Baby Steps interface to the practitioner. in the second step, we'll analyze the data every 3 months to figure out which sites are outliers, so who are the worst performing sites. And the third step is focused interventions for those sites, just for those sites. The study population is going to be the 36,000 VLBW infants that would probably be born in these NICUs in the next 3 years. The initial intervention will occur after collecting baseline data for 3 months. So the Quality Summit, Pediatric actually hosts 3 of these summits a year. They pay for at least one practitioner from every NICU to go to each one of these summits. The aims would be presented there, the existing comparative effectiveness research presented, and then the practice changes that we wanted to affect would be described. For baby steps, so as an example, for the interface for baby steps, if a practitioner elects to feed a premature infant formula, they'll get a warning that says you're feeding this baby formula. They'll also get links to their NICU's use data for human milk and a comparison to the Pediatrics Medical Group benchmarking of breast milk feeding. These graphs will be corrected for the demographics of that particular unit. In addition, if human milk is discontinued during an infant stay, so the mom runs out of breast milk and they have to prescribe formula, another warning will pop up that gives interventions by which the mom might provide more breast milk. This is just a screenshot of what this might look like. So at the top, this is a 970-gram infant. Somebody selected premature formula for this infant instead of human milk. They get this great big red warning with links to that unit's use of human milk, a link to the AAP statements, and there'll also be other links to interventions by which they may help counsel moms to provide more breast milk. This is an example of what it would look like for a baby who's on day 4 of AMP and GENT and has negative cultures. Again, a bright red warning, a link to the use of empirical antibiotics in that unit compared to the pediatrics benchmarking data, and a link to Mike Cotton and Danny's paper about how prolonged empirical therapy might be dangerous for babies. Similarly for ranitidine, a red warning, some use data, and a link to the article showing harm for H2 blockers. And then finally for steroids, a red warning, a link to that unit's use data, and a link to the AAP statement about how postnatal steroids should be used. There'll also be a link to some other strategies for getting a kid off the ventilator or to prevent chronic lung disease. So every 3 months, data will be downloaded from baby steps. We'll use regression modeling, logistic regression for the aims with binary outcomes, and Poisson regression for the number of days of antibiotics. To identify the site outliers, there'll be 3 steps. There'll be some exploratory analyses, the modeling, controlling for confounders, and then some confirmatory steps. This is a partial list of some of the confounders that we're going to use. Some of the confounders, like gestational age and birth weight, affect everything in neonatology, but other confounders may be specific for just one specific aim. So maternal age really should just be affecting the proportion of infants that are fed human milk. It shouldn't have anything to do with empirical antibiotics or postnatal steroids. In addition, for just the human milk aim, we're going to be able to link the information from baby steps to social, environmental, and demographic data. We're going to do this by having the addresses of those babies. Those babies will be street geocoded and then linked to spatial data layers. And those layers are going to include lots of community social stressors, crime, poor housing, community resources, access to public transportation, the availability of daycare for siblings, income, education, things that may affect rates of breastfeeding in those communities. This is just a brief flow chart of how the data will flow in this proposal. So down the middle is sort of the typical flow of data in the past for pediatrics. Data was collected at each individual site in baby steps. It then came to a consolidated clinical database that still had protected health information. And then over the course of a couple of steps, the protected health information is stripped out to provide them a research database from which they can look and do comparative effectiveness research or epidemiology research. In addition, we're going to provide Marie Lynn Miranda's group here in the Nicholas School of Environment with the mother's addresses, they will then link that data to geospatial data, then remove the protected health information and send those data sets here to DCRI, where we'll merge the data sets with a research database. And then we'll use that database to do the analysis for the 4 aims of the trial. Again, the purpose of doing the analysis is to identify which sites are the outliers, so the worst decile of sites in terms of their practice. Once we identify those NICUs, the director of their quality improvement will notify the medical director of that NICU and the regional president that's responsible for that NICU. Each site will get a quality improvement consultation to see if there are specific things at that site that are causing their practices to be outliers. There'll be any site-specific modifications that need to be made to baby steps can be made. All their practitioners can participate in a webinar session where they can hear the existing comparative effectiveness research, and then finally each site will be followed up with progress reports to see if they change their practice. Sort of another important part of this proposal is to look at clinical outcomes. So we want to affect those 4 specific aims: decrease in acid use, decrease empirical antibiotic therapy, but we also want to monitor the overall clinical outcomes. And so what we'd like to see and be able to do is quantify, do we see an improvement in outcomes of these babies? And some of the outcomes we'll be looking at would be overall mortality, time to discharge, number of late onset infections, chronic lung disease. And hopefully if we see a positive trend, then that'll provide positive reinforcement for the changes we're trying to make in these NICUs. We do acknowledge that there's going to be a potential for worsening of outcomes. So we may decrease empirical antibiotic use and then see a spike in late onset infections. And there may not be a relationship, but it's going to be something that we're going to have to monitor for every 3 months. We'll present the data to a steering committee, and we have some stopping rules where we would consider stopping those aims that might affect that clinical outcome. Just an overview of the timeline. So we'll spend 3 months collecting baseline data, and then in November we'll present the comparative effectiveness research at the Quality Summit and make the changes in baby steps at the same time. And then we'll begin a cycle of every 3 months getting data, analyzing it, and feeding it back to sites. Some of the limitations for this proposal: there's going to be some missing data. We've worked with these data sets before, and depending on which variable you're looking at, there are certain amounts of missing data. We do have some statistical methods to address this in the proposal. Probably one of the biggest problems is going to be unexplained confounding. And so no matter how many variables we collect in neonatology, there's always something about the baby that puts that baby at increased risk of that outcome or needing an antacid or needing postnatal steroids. And so although the data is fairly granular relative to other data sets that are available in neonatology, we're still going to be missing out on some variables. Although for human milk, we'll probably be doing the best job that's ever been done so far with the addition of the geospatial data available from the Nicholas School. And then finally, there's going to be some babies in this data set that have to have these therapies. So there are some babies that would be ventilator dependent unless they got dexamethasone. And so often neonatologists are faced with the prospect of giving a baby dexamethasone to get them off the ventilator or sending a baby home on a home ventilator, which is usually not the best option. And so there's going to be a small percentage of babies that have to have those therapies. Some babies will have to get formula if mom's HIV positive. And then some babies may get antacids because if they have a bradycardia, they code. And so some of those babies will need those therapies. But it should be a very small percentage of the overall population. Just as an example of what's been done before at Pediatrics in terms of their quality initiatives, Mike Cotton and Danny Benjamin here at Duke and Reese Clark at Pediatrics published a couple of papers that showed that broad-spectrum empirical antibiotic therapy, cefotaxime versus gentamicin, was associated with an increased risk of invasive candidiasis and death. This is data from the Pediatrics Medical Group showing what units used in terms of their empirical therapy. So across the x-axis, again, is each individual site. And as you can see, most sites used essentially 100% AMP and gent. There were a few sites that used just AMP and cefotaxime, and then there were maybe 20 or 30% of the sites used a mixture. What you would expect is that units might give AMP and cefotaxime to the sicker babies, but from this figure you see that most units just use whichever one they're used to using, so whichever one they had in their training, whichever one's on their formulary. They're not really using it specifically for sicker babies. And so based on Mike Cotton's paper and Reese Clark's paper, they instituted some educational programs, and the use of cefotaxime as empirical therapy for the initial course of antibiotics fell from over 20% to nearly 0%. And then they also saw a rise in the use of ampicillin and gentamicin. And so they have made positive changes in terms of their practice. And I'll stop there. I do want to thank Danny Benjamin and Ron Goldberg, who are co-mentors on my K23, and then Mike Cotton here at Duke and Reese Clark at Pediatrics. Thanks.
Good. Thank you, Brian, for a very interesting presentation and what sounds like a good score, and hopefully it'll come to fruition. I'm sure there's some comments or questions. Okay.
Yeah, it's with all this data, an interesting question is what's the most effective way to get people to change their behavior? Implicit here is an educational approach, that people didn't have knowledge of this information, and the studies that we've done here at DCRI, heaven forbid, and so they obviously couldn't do the right thing. But there could be other ways of thinking about it, and there's a lot of work on behavioral economics around campus. Dan Ariely's got a new book out. So you could also think about actually some kind of matrix model of different kinds of interventions in your different regions, that some of which could be pure education-based, some of it could be game-based, some of it could be information-based. So how do I motivate people to change their behavior as a sub-theme within that? Because even, Eric with Crusade data shows people that they're doing something that's killing patients and they still keep doing it. So how can we think about other ways of getting people to change their behavior? Because obviously most of the time we don't have anything as elaborate as the infrastructure you're going to have from this study.
So I don't disagree with anything you said, and I think we found that as a problem across pediatrics. I mean, these papers from Danny and Mike Cotton and Reese have been out for several years, and there's still lots of people who still use those therapies, even though it's in the published literature, and there's been plenty of presentations at national meetings about those therapies, and so we find it sort of hard for sites to uptake best practices, but at least Pediatrics has shown to be able to do it. For specific problems. They've also done this with similar methods with the use of Reglan at their site. So I didn't talk about Reglan for reflux, but it's another medicine where there's no evidence that it works. There's potential harms, and they've dropped their use of Reglan precipitously. But
now, are all the physicians employed by Pediatrics?
They are.
So the other thing is tied to their incentive compensation.
We did discuss that when we were talking about this proposal, but we didn't put it in the grant itself.
I wouldn't do it in the grant, but I would. You can sit down and rethink about what your interventions might be.
Mm-hmm. It's an interesting thought, and I had a related question to say that if you find those low performers and you provide an intervention and they still are low performers, what would the next step be? And it gets to the point about some other type of intervention, but you probably have a plan for those low performers that don't seem to respond well.
So I guess my understanding of how exactly the pressure works from the administrative side of pediatrics is probably not all that it should be, but our hope is that everybody improves with the initial intervention, that the secondary interventions all work, but obviously there's going to be some sites that don't work, and what sort of pressure comes from their administration there. I'm not sure how that works, but it would be interesting to see what they would be able to do for those sites.
Yeah. And the sites that do well, I'm sure you're going to provide some positive reinforcement there as well, or they're just good and they know it.
I guess their positive reinforcement would be they'll have feedback on their site's use data. So that sort of data is already actually being fed back even without this proposal. So sites get their use data on some of these interventions at baseline, so they know how they're doing compared to other units.
Question.
I've lived long enough that when my first baby came, I was ridiculed by the medical establishment because I planned to breastfeed, because they told me nobody does that anymore. By the time the next baby came around some years later, everybody's saying, oh, what can we do to get you to breastfeed? My question for you is, obviously this is an important link with your colleagues in obstetrics. How are there quality objectives for the obstetrical caretakers to inform women that if their baby should get in trouble and be born early, how important this is. I know it's important, period, but do you have a cooperative educational program with the obstetrical groups?
So we don't as part of this proposal, although a lot of the obstetrics groups are run under the same company. So there's obstetrics with an X, and so there's not 100% overlap with the neonatology groups there, but there's a good bit of overlap. And so there's a potential for intervention there. And I think as part of any program where a NICU is trying to drive up their rates of human milk, you have to have buy-in from the obstetricians, or you're not going to get anywhere near your goal.
Yeah, I had a couple of questions. One is, I think it'll be phenomenal if this is actually funded, given the way the government has responded to funding this particular private practice group. And I'll say that I had a streak of 12 consecutive funded grants and trials that hit a brick wall when I tried to go in with Pediatrics. So if this is funded, that's very nice. The second thing is that the idea of within 250 centers, you could randomize by center if you're able to get some compelling data that some groups of people really don't respond to education, which you will in this grant. The third is a question for you. We correct for demographics with, say, breastfeeding, okay? Is it possible that you're actually making public health worse by for a small subset of the babies, that is those of us who were born to a certain economic stratum, or parents with a certain educational stratum, or for the babies who are born of a certain race, by justifying to the clinician, here's an acceptable rate for, poor babies from Pickens County, South Carolina, whose mamas never went to college, how often we should get breastfed. Do you think, what do you think are the possibilities that you might actually make it worse for some subsets of babies?
So I think that's a possibility. I think what you give the NICU, though, is knowing where you stand based on your demographics. So if you should have, based on the whole U.S. and based on your makeup of your NICU, if you would expect 60% of your babies to be breastfed and you're at 50, then you're sort of falling below where you should be, and you want to make those NICUs do better. But you're right, there are NICUs that are going to be higher than they should be and may not, increase their support of those moms or make an effort to increase their breastfeeding rates because they're doing better. And they may just be doing better because there's another confounder that we didn't control for.
One of the things you might think about doing, since, you've got some areas like the Wesley Center in Wichita, is thinking about involving somebody who, Jay Kaufman, who used to be at UNC, is now at up in Canada, somebody who actually specializes in kind of demographics and epi to either have a spin-off from this if it's funded, or to collaborate with them, looking at that question nested within yours specifically. Since you're going to have the whole train moving forward, that's the sort of thing that a small early career award for somebody, one of those people who actually, that's what they do for a living, one of their trainees can just kind of hop on board to your enterprise.
Dana, I want to make sure I understand at least one of your points. Are you saying that for certain demographics that the definition of success, as outlined in this proposal, is bound to be different, and you may not see that immediately translated into changes in outcome, particularly some of the long-term neurocognitive outcomes that go along with some of the interventions like corticosteroids? Yeah?
Well, I think so. So yes. The short answer is yes. And number two, even more insidious, is that if I'm at they've got some units that are in Middle America that essentially cater to virtually all white English-speaking upper middle class citizens. Okay. Nested within that NICU, however, might be a group of babies who are from underrepresented minorities or whose mamas are not so well educated. And that group actually is virtually all never gets breastfed. But because there are a low fraction of that group, you get kind of the famous kind of ecologic fallacy that was discussed in Protestant versus Catholic suicides in France. Whereas, in these very wealthy NICUs who've got good overall rate, your stratum-specific rate actually is not good and gets worse as a result of your intervention because you're like, oh, dude, we're at 93%. Yeah.
Now I understand at least part of it. I don't understand the Protestant Catholic thing, and I can talk with you about that later. But nevertheless, it's a great point because nested within that group that seems to be performing well are some individuals that perform very, very poorly but don't end up getting singled out as requiring the intervention. So now I understand. Yes. So 36,000 individuals. And I didn't catch, you had some of your timelines, but how long do you think it would take to enroll your cohort? And then obviously you're looking at changes in behavior, and you're hoping that those changes in behavior ultimately translate into changes in outcomes. So how long will it take?
So all the babies born there so we're doing this without consent of the babies, and so we because we're doing this on babies without protected health information, and although Marie-Lynn Miranda's group is doing it with protected health information, she has protocols and ways to handle that sort of data that can be done without consenting 36,000 infants. And so as soon as this proposal would be funded, we would be pretty much ready to go into startup. I mean, most of these the proposals for the interventions have a fairly short turnaround time. And then we would expect to see changes in use immediately, and you would expect to see changes in outcomes immediately. So if you see a 5% drop in use of postnatal steroids, then we may see a spike in chronic lung disease, but I guess that's not a good example because we're not measuring neurodevelopmental impairment. But for breastfeeding in particular, where the outcomes are fairly dramatic in fairly short terms in terms of necrotizing enterocolitis. So if breast milk rates increase by 10 or 15%, we would hopefully be able to see some changes in mortality and changes in the rates of necrotizing enterocolitis.
And maybe there'll be an outcome for a separate RO1 type mechanism to look at neurocognitive, which is a much longer type phenomenon. I don't know if that's something that would be inherent to the way it's designed, but given the fact that you made the point twice that people have not done a good job to look at the long-term effects of corticosteroids, hopefully that won't be one of the limitations of your investigation.
So we hope not, although the only things here that have been associated with neurodevelopmental impairment are the things that we're hoping to prevent, although Danny's project that was in collaboration with Pediatrics was to look at a lot of neurodevelopmental outcomes in babies that we haven't been able to look at before. Mm-hmm. But that project's not funded, and so we're left with shorter-term outcomes.
Understood. Okay. Other comments or questions? Well, if not, I'd like to thank Brian for an excellent presentation, and good luck with your proposal, and thank you all for your attendance and your questions and comments.